And hopefully my lecture will be interesting for you, shedding some lights on the relation between the obesity and the kidney. Actually, let me start with a history of one of my patients. Actually, he is a young male patient, 33 years old. His body weight is 165 kilograms and his height is 185, with a body mass index 48.2. He is known to have hypertension at the age of 22, and he was on irregular treatment. He also suffers frequent attacks of acute gouty arthritis. The first presentation to my clinic was on 2008 with acute severe gouty arthritis, and at the time his uric acid was 15, his creatinine was 2.3, and he has a proteinuria of 2 grams per 24 hours, and with microscopic hematuria. He received standard treatment for the acute gouty arthritis, and he is improved and instructed to follow up. But actually, according to the type of the personality of the patients, he disappeared for 3 years to reappear again to my practice after 3 years with, again, acute gouty arthritis, which was diffuse this time. And before this attack, it was precipitated by faulty or misinterpretation of his case, because 1 week earlier, his blood pressure shooted to 220 over 130, and he received diuretics and allopurinol without protection with colchicine, which precipitated the acute gouty arthritis. And at that time, his creatinine jumped to 4.9, and his uric acid was 13. Again, he was treated, and he improved, and his arthritis much better, and his creatinine a little bit dropped from 4.9 to 4.4, and he was advised again to follow up. But unfortunately, he remained non-compliant for medical advices, and only on few years, at the age of 40, he is in dialysis. My mission today is to, all of us know that the chronic kidney disease mostly comes from diabetes, hypertension, and vascular disease. But my mission today is to explain and to prove to you that obesity is directly toxic to the kidney, not through an intermediate like diabetes or hypertension. But my mission today is to explain direct relation between obesity and the kidney. So my agenda is to give you proof from the epidemiological studies and to review what happened on the level of the physiology, what the physiological changes occurs in obese patients, and we will go to the structural changes occurs as a consequence of obesity, and if there is a solution, if the weight loss does reverse these changes in the kidney or not, and finally we will conclude. From the epidemiological studies, we have one study from Japan which showed clearly with more in males and females, with more increase in the body mass index, even at the 25, at the peak at 25, and it starts to increase the risk of end-stage renal disease with increasing body mass index. Another big study from Kaiser Permanente, which is a South Californian integrated management company, which have a lot of employees and patients to follow. Among more than 300,000 patients, they followed them over years, and they found almost 1,500 patients with end-stage renal disease, and they showed clearly with more increase in the body mass index, it's again strikingly starting from 25 body mass index, the risk for chronic kidney disease and end-stage renal disease exponentially and directly relation to the body mass index. Another study from Sweden this time, from Europe, and they followed a lot of patients, millions, 5.3 million patients, and this populated their population, and they found again the highest body mass index at any point in the lifetime is increasing the chronic kidney disease double, twice, two-folds, and body mass index less than 25 compared to body mass index more than 25, again, the risk for chronic kidney disease without diabetes or hypertension is 3-folds. Again, if he developed diabetes or hypertension, the risk is more and more. Another study showing that among almost 9,000 male patients this time, even the change in the body mass index toward increasing is increasing the incidence of chronic kidney disease in this patient. And another study showing that the more the patients have components of the metabolic syndrome, the more likely that he will have chronic kidney disease, microalbuminuria, 1 component, 2 components, 3 components. So the prevalence is increasing the more the components of the metabolic syndrome and also the prevalence of microalbuminuria. So epidemiological studies shows clearly that there is association between the obesity and the body mass index and the chronic kidney disease and the microalbuminuria. And one of the earliest studies kind in the literature showing this is describing a patient who is morbidly obese who has a nephrotic syndrome. My mission in the coming few slides is to explain to you on the physiological level how obesity disturbs the kidney and at the tissue level what happens inside the kidney. So this is again one study showing that what we call it now obesity-related glomerulopathy is increasing over the years. We have a distinctive pathological features of the obese patients. Pathophysiologically, all of us knows, because I'm now speaking to endocrinologists, that the adipose tissue is not a couch of potato. We know that there is more than 50 adipokines are released from these adipocytes. Mostly, all of them actually are inflammatory except adiponectin, and this leads to insulin resistance, inflammation, and hypertension, dyslipidemia, which consequently have the cardiovascular and renal effects. But actually, I would like not to emphasize on this too much, but to the mechanical and the hyperfiltration effect of the obesity on the kidney. One of the studies comparing the glomerular filtration rate between the normal and obese patients. Normal patients, normal body mass index less than 25 here in light gray, and dark black bars are describing the patients with obesity, and we found clearly that the patients with obesity with more than 25 body mass index, there is increase in the GFR up to more than 180 ml per minute. And what does it mean? This means that they are consuming what we call it functional reserve of the kidney. The normal GFR is between 100 and 120. The obese patients are filtrating at 180 ml per minute. They are consuming their reserve. And this overload actually leads to what we call it intraglomerular hypertension. Without clinical hypertension, it is intraglomerular. And this happens under normal conditions. The afferent and efferent arterioles have the same diameter, and the intraglomerular pressure are controlled. But in case of obesity, the more they eat, the more they have insulin and angiotensin and leptin, and this will increase the absorption of the sodium. This is why the obese patients tend to have lower limb edema and tissue edema. And the decrease intratubular, the more the reabsorption, the decrease sodium intratubular. This leads to what we call it tubuloglomerular feedback. If the tubules less sodium, they go to the afferent arteriole, make it to dilate. So when it dilates, it increases the blood flow, and the efferent arterioles maintains its diameter. So afferent increase in diameter, efferent maintains the diameter. This leads to hyperfiltration and increased intraglomerular pressure, which is quite injurious to the glomerulus. And this actually occurs with high protein intake, because this is the more stimulation of the hyperfiltration, leading to more increase in the intraglomerular pressure, leading to increase in glomerular filtration rate and the proteinuria. So physiologically, the obesity leads to hyperfiltration and adverse adaptation to excess sodium retention, adverse renal effects of hyperinsulinemia, insulin resistance, and there may be some lipotoxicity. If we go to tissue level to see what happens on the tissues, actually we have 3 residence cells, main intrinsic cells of the glomerulus: endothelium, endothelial cells, podocyte, and mesangial cell. And actually the mesangial cell is like the macrophage. It is actually derived from the bone marrow, and actually under the effect of the leptin, it increases the TGF-beta, and this is one of the fibrinogenic hormones, leads to increased collagen synthesis and glomerulosclerosis and proteinuria. And if we try to prove this, we have 3 levels of experimentally to follow to prove this structural damage. On the level of the cell culture, so in experimental animals, then in human studies. Actually, when they incubate the mesangial cells with more increase in mesangial cell in rat cells, increasing the collagen formation, and started to form nodules. And again, with rat mesangial cells exposed to insulin growth factor 1, they change it into foam cells. These foam cells is exactly like what happened in atherosclerosis when they start the macrophages engulf the excess lipids leading to formation of foam cells, and this is actually some similarities between glomerulosclerosis and atherosclerosis. If we go to experimental animals, infusion of leptins into rats leads to proteinuria, and when they are sacrificed and looking to the kidneys under the microscope, they found this is the normal glomerulus, and here it starts to form sclerosis nodules. It starts to have fibrosis. And actually, in dogs, these dogs are maintained on normal diet for 9 weeks, and they put on high lipid and high caloric diets for another 9 weeks, and this happens into their kidneys. This is the normal glomerulus again. This is the glomerulus after feeding these dogs on high lipid, high caloric diets for 9 weeks. It starts to elaborate more mesangial matrix, and here when started to immunohistologically, they are increasing the expression of TGF-beta. This is Brown's expression of the TGF-beta when it is compared to the normal diet. It is quite clear that some changes even after 9 weeks only for high caloric diet. And when they examined the size of the glomerulus, they found that there is what we call it glomerulomegaly. The glomerulus increased in size. It becomes big size, hypertrophied. And the more the body mass index, the more the glomerular hypertrophy and the nephronomegaly. And when they look at again, they started here sclerosis, here some sclerosis polar, here some increase in mesangial matrix, and it started the sclerosis. And they describe what we call it diabetes-like diabetoid changes inside the kidney by first increasing again mesangial matrix, ultrastructurally under the electron microscopy. This is the glomerular basement membrane, and this is diffuse thickening of the glomerular basement membrane. Actually, this actually occurs also in the diabetes. And here's the food processes. If you recognize it, this is some diffusion of the food processes, and which leads to proteinuria. So the changes which occurs inside the kidney with diabetes is similar to idiopathic focal segmental glomerulosclerosis, but they are different in some aspect. With obesity, it is little bit, the presentation is late, usually in the middle 40s, and the proteinuria is usually not nephrotic range, while in the idiopathic it is nephrotic range. Again, they have vascular and hypertrophy of the glomerulus on almost 100% of the cases. This is to differentiate between the idiopathic and obesity-related glomerulopathy. Again, this is another case, not mine this time, but it is in the literature. This is a 48-year-old morbidly obese man, 125 kilograms with 1.77 meter height, and his body mass index, again, 40, presented with massive proteinuria, 8.4 grams per 24 hours. His medical history included hypertension for the 4 years, morbid obesity, gout again, and impaired fasting glycemia, and his hypertension had been relatively well controlled with no known endogenous end-organ complication until the current presentation. This is his current presentation with massive proteinuria. And he has medication aspirin, lisinopril, and allopurinol. When we are confronted as a nephrologist with a patient with nephrotic range proteinuria, my aim is to check if he has some secondary forms. So we check the immunology, we check C3, C4, antinuclear antibody, we check for the famous infections, virology, and we don't find any cause to be incriminated for his proteinuria. And this is his biopsy. Again, he starts focal segmental glomerulosclerosis. And he received no treatment apart from a diet regimen. And after 18 weeks, only 18 weeks, his body weight dropped from 125 to 110, and his proteinuria dropped from 8.5 to 2.1. And after 6 months, his body weight lost to 1.2, and his urinary protein excretion was only 0.85. So, with decreased body weight, he managed to improve his proteinuria and kidney functions. So weight may reverse or delay the progression of the renal insufficiency. We have a lot of studies confirming this decreasing GFR and from the hyperfiltration, not in the opposite side, decreasing from normal, decreasing from the hyperfiltration state to normal. And we have a lot of studies showing this. After reduction of the body weight, there is decrease in the renal blood flow and the plasma flow. And another study showing that proteinuria also decreased and GFR decreased from the hyperfiltration state to normal state. By this, I would like to conclude that obesity has a direct relation to the kidney. On the pathophysiological level, it causes hyperfiltration and with increased intraglomerular pressure, which leads to sclerosis. And in structural level, it causes a diabetes-like or diabetoid changes in the form of increased mesangial matrix elaboration, thickening of the glomerular basement membrane, and some food processes from the podocytes fusion leading to proteinuria. And there is a place for reversal of these changes by decreasing the body weight so we can preserve the kidney. And again, eating is unavoidable toxic biological activity. We have to keep this in mind. Actually, eating might induce some inflammatory changes and some changes in the kidney, hyperfiltration. So the best thing is to keep our food in accordance to our needs, actually. And thank you very much.
Thank you very much for your elegant presentation, but I would like to ask you a simple question. At which level of body mass index one of us has to consider kidney dysfunction?
The kidney is
Dysfunction. At which level of body mass index any one of us has to consider the presence of kidney dysfunction?
Epidemiological studies actually show that at the starting increasing from 25, but this is epidemiological studies. On clinical grounds and in practicality, I think it is not so dangerous because we have to go in depth. Actually, at 25 exactly, we have damage or not. I think up to 28 is a little bit you are in the safe zone. But after this, the more you gain weight, the more that change, especially if there is a change. Even they acknowledge the change, not only the absolute figure, the change. The change means that you change it from normal diet to diet which is more than the metabolic needs. So it will be damaged. There will be a damage. So I think after 28, we have to sit down and look what's our diet, how to control our weight.
That is in the absence of hypertension and diabetes, simple obesity. Simple obesity.
Simple obesity is actually injurious again without this hypertension and diabetes, but actually is much slower than if it is combined with diabetes and hypertension. But when the patient reaches this morbidly obese state, it is hardly, if ever, you will not find him hypertensive. If he reaches the body mass index of 40, it's very difficult to find this patient not hypertensive, actually.
Thank you.
Morning. Thank you very much for your elegant talk. I would like to ask about the effect of dieting on the kidney function in obese patients as regards uric acid, eGFR, creatinine, and also the effect of bariatric surgery on the kidney function.
One of the slides showed that after bariatric surgery, GFR changed from hyperfiltration to normal and proteinuria decreased.
Uric acid.
Uric acid with diet, actually we
With
have
diet.
a place for uric
Increase.
acid to decrease with diet.
Yeah.
And at the level of the GFR, each meal, especially if it is high protein diet, actually it has a direct effect in the GFR. And we saw this actually in kidney transplant donors. These donors, if they come to us with GFR is less than 80, his body mass index is low and the muscles is low, we might have normal, especially in Mediterranean diet, and the GFR might be 78, 80, and this actually worrying to us in the transplantation. We want to increase his GFR. We go tell this donor, please go, eat too much meat and repeat GFR. Next day directly, we find it 100. So it has a direct effect. High protein diet, especially high protein diet, has a direct effect, immediate effect on the GFR.
Thank you. Yeah. قدمي أستاذ أيمن.
دكتورة إيمان. دكتورة إيمان.